Everyone. Hope you're doing well. We are just about to start this live with Dr. Joshua, and I've invited him along. Just wait to see when he appears. We've got a couple of minutes to past, so I am just going to say a big hello to all these people joining us. Hi, Cal, lovely to see you. Got lots of others joining us, so yeah, looking forward to spending some time with you this evening. I'll do a proper introduction when Dr. Joshua meets us. I'm sure he's on his way, and we're a few minutes early, aren't we? I hope you've been having a good day so far. It's a very rainy one here in Bournemouth. Don't know what it's like where you are, but it's, yeah, the sunshine is not in Bournemouth, sunny Bournemouth. So we are really excited to be able to hold this Insta Live this evening with Dr. Joshua as part of Eating Disorders Awareness Week. As you know, the theme is around doctors training, so it's really exciting to be able to invite Dr. Joshua to come and join us. I am just going to try and invite him again. There we go. I can multitask, can't I? There we go. Wonderful. Dr. Joshua, are you there? We're still a minute early, aren't we? How's everyone doing? Give me a good old wave wherever you are. Where are we joining from today? Say a big hello to us from wherever you are. Nice to see people joining from the nations as well. Lovely to see you here too, Carly. It's bright in West Cumbria. That's really good to see. We've got people from London, from Paris, amazing, and beautiful York. Canada, gosh, I think we've got a competition to see how far everyone is away. So Dr. Joshua, good question. He has written a book called Food Isn't Medicine, and he has been quite spoken out on social media talking about diet culture, but he has suffered with disordered eating himself. So he talks about his own journey through to recovery and wellness. There's Dr. Joshua. Shall I invite you again? Let's just see. There we go. Wonderful. Hopefully we shall have him on screen in just a second. Very prompt, Dr. Joshua. There you are.
Hello.
Hello. How's your day been?
It's all right. It's been busy, and it's only going to get busier, but I feel like it's good just in general. But that's all right. It's fine. It's one of those days.
Tuesday, and it's 5:30. And
well, I know.
We're gathering together. So, Dr. Joshua, could you introduce yourself, and then I'll introduce myself, and we'll set the context for this evening.
Yeah. I was going to say, well, Jess, nice to finally kind of actually see you. We've been having several back and forths by message, but it's nice to finally put a face to the words as well.
I invited you to an Insta Live on the 29th of Feb, if you recall.
Did you?
I did, and then you said, no, 29th of Feb, Jess.
Well, there we go. So I'm technically Dr. Joshua Wolrich, although Josh is far more normal. I'm an A&E doctor. I used to do surgical training, used to work kind of mainly in orthopedics, but I've changed career path because of the fact that actually I want to be working with people on their relationship with food, and running a business whilst being in the hospital doesn't really work if I do surgical training. So I'm now back in A&E. I run a nutrition business called Weight Neutral Nutrition, and I work with people on their relationship with food, people with disordered eating, not people who have established eating disorders, because there's a lot of complexity there and I don't feel qualified enough to be able to do that yet. But hopefully at some point in the future, I may be able to do that as well.
There, we like that.
Yeah. And as we may talk about, I haven't exactly had a huge amount of experience in eating disorders, specifically through medical school or post-medical school either. So I want to make sure I have some very specific training in that, to help people who are dealing with eating disorders specifically. I what else do you want to know about me? I've had like a really interesting social media unintentional influencer thing journey, let's put it that way, of starting on social media, creating essentially a weight loss account, which is kind of what I mean, you'd hope that it wasn't what 90% of Instagram is, but I feel like it kind of still is nowadays, because it's such a visual platform, right? And it's such an easy platform to use for photos, transformation photos, food photos. It's something that I think lends itself well to people who, like myself, were looking for a way of utilizing shame to what I thought was going to be improve my health, but it wasn't about health. It was about making me feel more worthy of being a doctor, because I thought I couldn't be a good doctor if I was fat. That's kind of it in a nutshell. I do not do that anymore. I came across some really fascinating research and people who spoke about food and the fact that a relationship with food was even a thing, spoke about the complexity around weight and health and how it wasn't as straightforward as actually I'd been convinced of and taught about in medical school. The harms of dieting, the harms of labeling body size as a pathology, and telling people that this obsession with being thin was actually about health when it almost never does. And I ended up going on quite a long journey, culminating in realizing that I couldn't be consciously or morally advising patients to lose weight anymore. I definitely couldn't be doing that on social media, and did a very slow 180, I would say, around these topics. Yeah.
Very remarkable one, I would say.
Well, hopefully, but I think a slow one is a good one, right? Because instead of doing a quick turnaround, which often feels a bit like a snap decision, I struggled massively with these kind of topics, and I believed that I could heal my relationship with food but still lose weight at one point. I believed that if I just helped people heal their relationship with food, then weight loss would suddenly be possible and non-problematic. And then I realized I just was lying to myself, and I couldn't really believe these things, and it didn't make any sense. And it's, yeah, now it's so much better to be dealing with these topics and talking about health in a way that is weight neutral, in a way that actually focuses on people's health, and health markers, rather than weight, which is, a side effect a lot of the time of things that take place in our lives that we don't really have a huge amount of control over.
Yeah.
But yeah, there you go. There's me in a bit of a nutshell.
I think our conversation today is going to be really interesting, because obviously you're a doctor, and we'll talk about, some of the training you experienced on your journey. I'm a therapist, and obviously, some of what we're going to talk about today, and our slightly provocative title was around, do decisions made by doctors impact, people's journey through recovery of eating disorders? And we hear from our beneficiaries all the time, don't we? Like, and certainly through this week, we hear from them saying, I went and had an interaction with the doctor, and he either said my weight wasn't low enough or I wasn't ill enough. I just wondered, as your experience of a doctor, how do we respond to that? How, does that impact someone's recovery massively, do you think?
Yeah, I think it does. I think one of the biggest things is the fact that we normalize behaviors that are otherwise incredibly disordered when it comes to our eating habits. We normalize eating disorder behaviors, right? And we justify that as just methods of trying to lose weight. And as healthcare professionals, and as doctors specifically, we're some of the biggest culprits to pushing this kind of message that weight loss is the goal. And it doesn't really matter what happens in the meantime, because, and my justification right at the time, I slipped into some, I won't specifically talk about them here, because I know there are lots of people who will be kind of watching this who do have eating disorders, who are struggling big time, and I don't want to be triggering people to be kind of coming across stuff they don't want to be. But I've talked about this kind of stuff in my book, and I've talked about this stuff on my page in the past, where I developed behaviors that I don't really know where they came from, but I developed behaviors of new ways of basically eating less food, that were incredibly harmful to me, both mentally and physically, But I justified them in my head that, well, they were just a means to an end, right? My whole goal was I needed to be thinner. And so it didn't matter whether I was causing harm at the time because I wasn't going to do it forever. Right? That was the logic I had in my head. And I'd like to say that I was a bit more clued up on this kind of stuff because I was a doctor and because I'd gone through medical school, but I wasn't in any way, shape, or form. And I think that we forget that doctors are people as well. And doctors have also grown up in that society of believing that thinness is the goal and believing that weight loss is something to be pursued at all costs. And unfortunately, because of the fact that none of that stuff has really been, if we could put doctors through a regime of working on their relationship with food at the beginning of medical school, I think we'd do some wonders. But because we don't, and that just doesn't happen, it's not even thought of, we end up with people in positions of power who, when they're told about certain behaviors that a patient may be doing, or certain techniques or tactics or whatever kind of word you want to use to describe them, they're often just kind of excused as, oh, well, you're just trying to lose weight. Okay, then. And people don't really pick up, doctors don't pick up on the fact that actually these behaviors are really harmful, because if we have it in our head that thinness is the goal, and we practice medicine in a way that is weight-centric, where we believe weight is the be-all and end-all of someone's health, then we're often going to be praising people for those kind of behaviors rather than actually stopping and thinking and going, is this actually causing them harm? Is this something that...
Isn't it? I think in our training, we talk about how, those symptoms or physical symptoms we see, actually there's so much underneath that needs healing and working on and processing, mental and emotional health, social health, so important. So I suppose my question would be, as a doctor in your training journey, because part of our campaign this week it's called Worth More Than 2 Hours. We've completed a survey and we've asked doctors how much training they've had. And it's less than 2 hours on eating disorders throughout their whole career. So what, you don't have to name the medical school that you went to, but how much training did you have?
I was at Imperial College. I don't remember. I'm sure I can probably scour through. I've got all of the lectures saved somewhere. I haven't looked at them in a long while, but I'm sure I can probably scour through and have a look. But I feel like I remember there being one lecture specifically talking about different types of eating disorders, and that would have been within the context of talking about psychiatry, right? So it would have been very specifically related to that kind of subspecialty and that kind of field of medicine. But it wasn't really talked, I definitely remember it wasn't talked about in relation to other patients presenting with other things. And just the fact that eating disorders don't just happen by themselves, that often there are people that have other health conditions. So people are going to be seeing their doctor about other things too. And we need to understand, I believe, we need to understand a lot more how that part of someone's life and that part of someone's medical history impacts the appropriateness of certain things that get said, the appropriateness of certain attitudes that get taken. And I mean, look, it's going to come up at some point, and I thought, I might as well just bring it up now. The appropriateness of the way that we talk about the nice guidance around things like obesity management as a concept and eating disorders themselves. And I know there's been a bit of a conversation happening this week around Beat and some of the messaging that they have. And I know you're clinical, which gives you a bit of an extra element of expertise here. But not everyone in Beat is clinically trained, right? Not everyone is clinical staff. And there's concern around, actually, if we're going to be agreeing with some of the nice guidance around eating disorders, so the nice guidance actually saying that weight management from an overweight / obesity perspective should be a part of someone's eating disorder management eventually, if need be. The fact that exists kind of shows one of a massive problem that we have still within the way that we think about eating disorders from the medical community and from that side of things. Because if we're even considering that somebody who's gone through recovery from an eating disorder would then be appropriate to be deliberately trying to lose weight, I think really that kind of highlights the big problem we still have.
And I think, you know, what is the, you know, we're really happy to meet and engage with people and listen. You know, I think this has been such an important journey this week in terms of for us as an organisation, and we're really happy to listen and think through this more. You know, from our perspective of all the, obviously the support and treatment we provide, we can 100% guarantee there is no weight stigma in terms of our services, and in that journey from where we pick, and no support we provide is based on any kind of weight or BMI. But we know that, you know, everywhere. But yeah, these conversations need to be had, don't they? And, you know, there's a lot more conversation to be had, research to be conducted, and bring it into mainstream.
It's just hard, you know, because because this was, so if I can be honest with you, this is something that for people that don't know, there's been conversations, right, in the last week around whether Beat as an organization, as a charity, actually needs to change some of its messaging around obesity management as a phrase. And, you know, having quotes on the Beat website, such as saying, we recognize the importance of reducing obesity, that quote in and of itself, and, you know, I'm not paid by you guys. I like the work that you do. But from my personal perspective, that feels inappropriate to be being said by a charity that is supporting people in eating disorder recovery, right? And just that there's a dichotomy there. There's something that just doesn't seem to fit between those two things. And I think there is the reason why I want to bring it up in this, not just because of its relevance in the last week, but because I think that is kind of a bit of a sum up of the way that the problems we still have within the medical community too, when it comes to managing eating disorders, where we still hold on to this thought that weight loss and weight management as a phrase, which I hate that as a phrase, full stop, right? I mean, your weight is not something to be managed, but we holding on to this thought that actually the two can coexist just doesn't make any sense. And it's just something that for someone who is seeking help from a charity and they want them to be on their side, I know that the support that you guys give, I wouldn't be doing this live with you if I didn't trust that, right? I know that the support that you guys give is fantastic. And I know that the support in terms of eating disorder recovery and stuff isn't led by weight stigma at all. But when you're someone who's then seeking help and you're seeing those kind of messaging, it's really confusing. You know, I know it's confusing for me, and I'm not seeking support from you guys. So I can only imagine how confusing it is for someone who is. But, you know, I'm looking forward to talking more about this kind of stuff more formally, right? But
we're inviting people, all those people who've raised concerns. We want to have that conversation. You know, we want to do better. We don't want to be causing anyone any harm. And we align so much with what you're saying, and I think we're really open to looking at any language, or if we need to shift, we're open to that and looking into it. So I can wholeheartedly promise that we will do our very best to ensure that no one's feels like they're coming to harm as a result of any kind of weight stigma. We're on the case.
Good. Which is why I want to do these kind of things, and why we've been talking for quite a long while about this kind of stuff. It's why I sent you my book a long time ago. Do you know what I mean? Of kind of going, I trust you guys and your expertise, and I want to know, you know, how is the reason I sent you my book was because I wanted to know, you know, how suitable is something that I write going to be for someone who's specifically in eating disorder recovery, because it's stuff I think about. Right? I just think this stuff is so ignored a lot of the time. But look, should we talk a little bit about the kind of atypical as a phrase?
Yeah,
in terms of eating disorders, because I think that's a fun one, right?
Yeah, go for it.
So it's definitely something that has come more to my attention more recently in regards to the way that and again, it links into this thought that people of larger size can't have eating disorders, right? And it links into this assumption that eating disorders are something that only thin people get. And it's definitely a myth that is perpetuated by the medical community. And
of people with eating disorders are underweight, isn't it? Something around that.
Yeah, I mean, I'd argue it's probably even less, right? If we were starting to really acknowledge.
Yeah, a lot of eating disorders are not recorded and people don't come forward, do they?
Well, I mean, just the fact that disordered eating and eating disorders can be seen on a sort of a spectrum, right? Of kind of everyone with a diagnosed eating disorder has disordered eating, but not everyone that exhibits disordered eating is going to then go on to develop an eating disorder. I myself felt lucky to fall into that latter camp. I don't know why. I don't know, some sort of undeserved resilience that may have come about. Who knows? If we knew why some of these things happened, we'd be much better at helping people. But unfortunately, there's incredible complexity there, as you well know. And I'm just learning, right?
Well, we all
But,
are. We're all
well,
learning.
I know
You know,
we're all learning more as we go.
15 years, have lived experience as well. I'm still learning all the time.
Yeah. But the fact that actually it's taken, I mean, when was the guidance changed? When were the diagnostic criteria changed? What was it, like 2, 3 years ago? When was it?
It only became a recognised mental health condition in 2013, didn't it?
That one, yeah, that one was not that. That one was, it was a bit longer. But when was the word atypical started? So when did that start to get used?
2017, I think.
Okay, yeah. So that's only like just over 4 years, right? And even then, I would argue it's probably the wrong word to be using. But essentially, now we treat people that are living in a larger body who are exhibiting all of the kind of behaviors and signs of an eating disorder, but don't meet the BMI criteria. And we all know that BMI is utter nonsense in circumstances like this, where we are now labeling them as atypical, where we're saying, oh, well, you could have an eating disorder, but you're atypical. But the problem with that is that it still creates this label of you're different, or you're not quite the same, or you're not quite important enough, theoretically, right? And I don't know, I don't like that word as as a word that gets used. I wish we could just call it anorexia nervosa and not actually have to label it as atypical because somebody's BMI isn't low enough. And I understand the benefit to.
It's tidy kind of diagnostic categories, isn't it? And putting people in boxes, but generally, eating disorders are a distress, a morbid preoccupation with food, weight, and shape, and that can happen in whatever size body you're in.
Yeah, and you don't have to get thin enough to be worthy of treatment or worthy of help, right?
And
And
no, and I think we focused last year on binge eating disorder for Eating Disorders Awareness Week, and it broke my heart listening to so many people just say, I've never even had any compassion towards me. Like, we had some of our beneficiaries come to focus groups, and they said, this is the most amount of empathy I've had in my whole journey from having binge eating disorder just coming up. And I was like, oh my goodness, this is 1 hour and we're here to kind of hear your story. But that is the level of shame and difficulty around, for some people, suffering with eating disorders in a larger body.
well, again, because we see weight loss as a supposed goal in all circumstances, right, within the medical community a lot of the time, it means that if somebody doesn't fit that criteria, then regardless as to the behaviors or the preoccupation or the actual kind of impact it's having on their mental and physical health, it's kind of just disregarded as, well, you're on a journey, right? You're on a journey of losing weight. That's okay. And I think there's nothing that encapsulates this more than actually a lot of the arguments. So I have conversations with people and conversations with medical professionals about how working with patients in a weight neutral manner is such a more evidence-based way of actually improving people's health. And that actually dieting and deliberate dieting to try and lose weight for the vast majority of people just doesn't work, because people put weight back on and they end up gaining more weight than they lost in the first place and all that kind of stuff, right?
Exactly, their symptoms. So if you tell someone with an eating disorder to lose weight, then their binges get worse because there's emotions, there's emotional distress driving that. It's like the worst thing you could possibly do to someone with binge eating disorder, and we totally advocate for that. I mean, did you ever get taught about binge eating disorder in medical career? Have you ever any training anywhere?
Because I graduated in 2014.
we've got some comments around let's get every medical school having our training and having eating disorders
Yeah.
training.
So I graduated in 2014, and I don't remember binge eating disorder being a thing that was ever mentioned. I remember talking about bulimia. I remember talking about that as an official diagnosis. I don't remember very much more than just a description of what it was and the kind of criteria that people would have to fit to be diagnosed as having it. But no, there was definitely, even if well, you said binge eating disorder came in 2013, I must have, my lectures probably around this kind of stuff and the psych kind of lectures that I had were probably earlier on in my medical school, 6 years. So it may well have been beforehand, or even if it was after, it wasn't incorporated within it. So I definitely didn't, it's definitely not seen still very well as an actual eating disorder. It's more just seen as just something that people do because they're having a cheat day, right? It's again, it's all of this stuff about normalizing these things, and the fact that society teaches us that these things are completely valid and acceptable because they're just weight loss techniques. And
I think it drives people, into that secrecy, doesn't it? And they're not able to really speak about how they feel for fear of being judged and, just treated as a symptom, not as a mental illness. And I think, that's what we were so we felt was really important to highlight last year, binge eating disorder in particular. And awareness and training around eating disorders. So, I'm really conscious as we're writing some training for GPs at the minute in collaboration with Health Education England. We have to remember that, to bring all I guess the spectrum of eating disorders in there, but also I'm just thinking other presentations, type 1 diabetes and eating disorders. It's really we're able to train doctors to spot people with eating disorders who are autistic. It's very different presentation, but there's so much more that needs to be taught. So, and I remember we had a junior doctor who helped us write the medical training that we're rolling out now as part of our campaign, and she just said, she's like, we learn about these conditions that I've never ever encountered in my placements as a junior doctor. Why can't we squeeze at least half a day on eating disorders in the curriculum? So, Dr. Joshua, what was the most random thing you were taught about in medical school that you've never encountered so far?
All right, the first thing that comes to mind, something called micturition syncope, which is where people go to the toilet and when they're weeing, they pass out. Like, it happens, sure, but I feel like in terms of the grand scheme of things, obviously we didn't have a half day. I just remember that was the most random thing I learned, but there are definitely things that actually we're going to come across and we could learn about later, right?
Right.
But things that we need to be able to pick up on from day one of being in the hospitals, straight after medical school. The number of, like, I learned about dysbulimia, right? I learned about the diabetes and eating disorder kind of combination and link. I learned about that from the BBC was it a BBC documentary or a Channel 4 documentary?
Wasn't it a really good documentary?
Yeah. So like that, I didn't know anything about that before then. That's a problem, right? That is an issue because we're meant to be able to manage and help people with diabetes, full stop. And if this is something that is common, right? And now whenever I see someone that has type 1 diabetes and they're coming in with, especially coming into A&E, because that's often the place where some of these kind of things can be picked up, because that's the kind of time when they don't have an option but to present to a healthcare professional. These are things that go through my head immediately now because I feel like it's important. And if that's not what's going on, that's great. But the fact I didn't even know what that was is a problem.
It's
right?
And it's really hard eating disorders to recover from. You have to manage your blood glucose levels. There's so much language from health professionals around good and bad glucose levels. A whole chat for another day, which about learning more about as well, type 1 diabetes and eating disorders. We have got the most important question come through that I cannot leave the live chat without asking. The coffee obsession, Dr. Josh. The coffee.
I've actually got
Explain on.
I've actually got a coffee watch on today as well, which has a little coffee cup on the bottom. Look, coffee's great. What are you talking about? It's not an obsession. It is a love, and it is a hobby that I've always loved cooking. I've always loved food, which was why it was so hard for me to go through periods of not enjoying food and food just becoming so stressful and anxiety inducing for me. And I for me, coffee is a bit like baking. Like, it's a recipe, and it's something that you can tweak and you can alter and you can change the flavor of things as you go. I know for some people that might make no sense because they just scoop a spoonful of instant and mix it in. But
Beanies, which I think is going to be like an insult to you. The flavoured coffee. I feel like you might swear at me for saying that.
no swearing. But yeah, I might need to get you proper coffee. It's something that should be enjoyed. It's exciting. I never learned to like coffee until more recently, so I think that's probably why.
You needed the coffee.
Well, yeah, so I rejected it for a while. I started working as a doctor and I was like, no, I've never drunk coffee at medical school. I always just had like the occasional Red Bull. I was like, I don't need caffeine, it's fine. And then eventually I gave in and I kind of grew to kind of enjoy it for the flavor. And then now I've started making it myself at home. It's become a healthy obsession. That's what I'm going with.
If there's a thing, Dr. Josh. So, I mean, there has been a really lively conversation going on in the chat. I mean, I'm aware that we have, raised some fairly, some poignant points. Can I say that at 6 o'clock on a Tuesday? I'm gonna. Obviously, we want people to reach out and gain support. I just wonder if some of the things we've been talking about today, people might have not had any concept of, or had any concept of the fact that there could be a level of discrimination around, people with eating disorders and larger bodies. So I think what we'd really obviously like to draw people's attention to is the chat, the support, the Beat helpline. We really want obviously people to reach out and support, but we also want people to sign up for the campaign. So there's been a lot of love for us talking about type 1 diabetes and eating disorders. And we have got some training coming up for that on the helpline, but obviously we want people to sign up for the campaign too, and anything that anyone can do to ensure that the training that we've got gets into medical schools. Obviously we want as many people to support us with that campaign as possible. And in fact, you came along to one of our webinars, didn't you, Dr. Josh? And when we were trying to skill up the facilitators in the medical schools, you popped in, didn't you?
I did. It was good fun to see, just briefly, but it was good fun to see that kind of stuff working. And it'll be great to see some of that stuff in person too, right? So I don't know if you have specific agreements to be doing lectures and stuff, but this is the kind of stuff that needs to happen. Even if it's just an hour, you need to just take a lecture slot in medical schools and start going and actually just presenting people to the idea that this stuff is important.
Yes, just go and plonk ourselves in a lecture theatre and demand. I like that.
Well, you could try that. but as this stuff starts getting accepted that actually it's more important in the curriculum than we're giving it credence for, these kind of lectures need to take place where, and there's merit to doing the kind of classic thing of, let's show a video of somebody who's talking about their experience of eating disorders. That stuff is useful. But also I feel like that stuff already takes place when it comes to the site. I remember that, I feel like that happened while I was in medical school. But the conversations that don't take place are actually just conversations around just how important this is, regardless as to whether you're working on psych, right? You don't just need to understand this stuff when you're going on a placement in a psychiatry ward. You need to understand this stuff when you're actually just seeing every single patient that you have. You need to understand this just as much as you see the importance of understanding something like depression, right? You need to understand this just as much as you understand the need to understand something like not having a fixed abode, right? Or being homeless, and how that might impact someone's ability to be discharged from hospital. We should know this like the back of our hand. It's a thing we think about, full stop. And I think those are the messages that need to be drilled home when we're having lectures at medical school about this kind of stuff.
I summarize it saying, how can we get doctors to think eating disorders and in each situation? Because 6% of adult population, prevalence is fairly high. So,
Mm.
you know, when I've met some foundation doctors, and, you know, even some curriculum leads, so I've never met anyone with an eating disorder. And I'm like, I think that
Think you have. Yeah.
you definitely met someone that didn't tell you. And so
Mm.
I think it's being skilled as practitioners to know how to ask those questions, because quite often people with eating disorders will not tell you. You need to find a way of asking, and asking appropriately and in an empathic way, to show you understand and want to support.
But not just, last thing I would say, not just ask those questions, but know what it means when someone answers you, right? Because we can all learn, and we do this a lot as medical students. We learn certain questions to ask about certain conditions, but it doesn't really start to make sense until you actually you actually feel like you know enough about the condition to be able to understand what people are saying back to you. And I've done a few talks at medical schools about my own experience in this kind of space, and talking about the importance of the fact that we all have a relationship with food. And the kind of thing that I end on when it comes to these kind of talks is, I basically say, you know, what would happen if you knew to ask patients what their relationship with food was like, and what would happen if you knew what it meant when they replied to you and told you, right? Like, it's not just the question, but it's, if you ask about their eating habits. And, you know, I got to use these kind of skills that I've developed specifically in A&E the other day, around a patient that it was important to be having these conversations with. But I know full well that those kind of conversations probably have never taken place with them. And I know full well that even if one of my colleagues knew what question to ask, they may not have known how to continue that conversation. And so it's not just the start, it's that whole getting comfortable with actually knowing it. And a lot of that requires challenging the assumption that losing weight is important, and challenging the assumption that weight loss is going to improve someone's health. Because if we ask the questions and they say, oh, well, I'm just trying to lose weight, the response from doctors is often going to be, oh, okay, cool. And that's we started on that topic, and, you know, that's a big problem. Like, I think that's one of the biggest barriers to actually getting more understanding here.
As we conclude, I'm going to give a plug for your book, because I really enjoyed reading it, and you know, I would encourage people to read it. I think, you know, a lot of I used to help support and facilitate a health awareness group in an inpatient service for people with eating disorders. We used to run a group called Health Awareness Group every week, and I wish I'd had that book to be able to offer to some of the people we were working alongside, because it's the truth. You know, with so much rubbish out there, you know, wellness bloggers and all this information on Instagram, I would really suggest people read it and arm themselves with the truth. And I think you've done a really good job of actually explaining some really difficult concepts in a really palatable way. So I just want to thank you, Dr. Joshua, for all you do and for working with us and supporting us. And yeah, it's been great to speak to you, and I'm sure we will speak to you again soon.
No, definitely. Thank you very much, and thank you for your kind words. And the only thing I would say, because there may be some people who are like, but the title's Food Isn't Medicine, and in my eating disorder recovery, I've come across that phrase and I've been told that food is medicine, right? And just to say, the reason for me using that phrase isn't to invalidate that as part of your recovery. That can be really important to people's recovery when they're, especially as an inpatient, or when they're in kind of the depths of dealing with this kind of stuff. But as you start finding the ability to repair your relationship with food, then actually challenging that concept, personally, I believe, is quite important. So I'm not invalidating the messaging you've been told by the eating disorder team that you work with. This is more as you start moving on your journey and journey of recovery.
Absolutely. Thank you so much, Dr. Joshua. You take care. Have a lovely evening, and
thank you. You too.
Bye for now.
Bye.